In this video, a multidisciplinary team from the Providence Cancer Institute in Portland, Oregon discusses how to measure success in a lung cancer screening program. After your lung cancer screening program started, how did you assess patient outcomes?
From the very beginning of our program, my colleagues and I felt it was very important to keep track of patient outcomes and then to be able to compare them to the NLST and to other academic centers, how they were doing. And so that's precisely what we did. And we discovered within even the first 2 years that the number of cases we were diagnosing and the percentage of lung cancers we were finding was very similar to the NLST.
So when we started our program, we also had IRB approval to maintain a database to keep track of outcomes of those enrolled in the program. And that was important because in any screening program, you need to demonstrate the safety of the program. You need to demonstrate the success of the program. The main finding or the main success criteria would be, did you find earlier stage lung cancers? And when you did, could you treat them without having excess morbidity and mortality?
We didn't measure success for a long time because you have to have enough clinical volume. And so what our plan was always from the beginning was to keep rigorous accounting of our clinical experience and to publish it, to either validate the NLST or to show that it can't be done outside of NLST centers. So ultimately, the way we measured it was by looking at our outcomes. So what was our positivity rate? What was our intervention rate? What were the complications from interventions? What was the stage shift that we saw? So that's really what the NLST was reporting, and that's ultimately what we reported, reporting results very similar to them. Of 95 lung cancers that we found, and of the non-small cell, so some of those were small cell, 70% of those were stage 1 or stage 2, or early stage. In the NLST, it was 65% were early stage lung cancer. So very similar. The whole reason for screening is for stage shift. The main point of the American Academy of Family Practitioners and their lack of endorsement of lung cancer screening is that we don't know if it's generalizable because of the expertise on cancer and thoracic disease management of the 33 NLST centers and the fact that they had such excellent surgical results. So the surgical mortality in the NLST was 1% to 2%. The published surgical mortality during this time frame for pulmonary resection was about 3% to 5%. Our thoracic surgical mortality was in line with the NLST. And that actually is what changed the mind of a lot of primary care physicians.
What would you say to colleagues at healthcare systems who think they may lose money on screening?
In order to have a program, there are going to be expenses. So we pay for a coordinator or a navigator who's a full-time position. Since now it is approved and insurance companies will reimburse for lung cancer screening, there is payment for scans, there's payment for individuals who need to be evaluated post-scan. So there is some amount of reimbursement. Over the last years, Dr. John Handy worked on evaluating the payment and whether or not money would be lost in a screening program. He could only look at our program, but his findings demonstrated that there wasn't a lot of money made, but that the institution did not lose money on the screening program. It was a slight benefit. So I would say to systems that the reason to do lung cancer screening is, number one, there's data that shows that it can be done well and that it can decrease lung cancer mortality. Number two, in our experience, financially, it will not be a burden, but it's not a huge moneymaker either. It's something that can benefit your area and your hospital, and it's definitely something to be considered as long as it can be done well.
From a practical perspective, how can screening rates increase?
Given the disappointing statistics of how few patients who are eligible for lung cancer screening actually get lung cancer screening, Our program recognizes there's a lot of work to do on many fronts. I think that personal awareness of screening is extremely important. Many patients out there, or many people who are potentially eligible for lung cancer screening, are not aware that lung cancer screening has been shown to improve survival. And many are not aware that there is lung cancer screening, frankly, at all. Many of the patients who are at the highest risk are also in demographics that may have very low health literacy. They may have avoidance of healthcare. They may have limitations in terms of access to even social media or other media that may be trying to reach out to supply that message. If there was a greater awareness overall of the potential impact of lung cancer screening, I think more patients would really be motivated to pursue it.
I think the ways to consider increasing that pool, that group of patients, is by getting the word out to PCPs. Now, that's been successful in our program in that the Providence Medical Group, the largest group of primary physicians who use this hospital, have really bought into the screening. So they have really made this program successful by enrolling their patients.
Well, first off, lung cancer screening is hardly being performed at all. So we've done a lot of lung cancer screening. We've had 5,000 individuals referred to us, but Portland Metro has 2.5 million people in it. And I'm sure, even though Oregon is pretty health conscious in general, that a substantial portion of them have been or are cigarette smokers. So we, despite being a busy and big program, are screening a small minority of people who potentially could undergo lung cancer screening and have curative intent treatment of or identified early lung cancer. So I think you increase it from two ways. One is making it part of the practice pattern of the primary care provider, as we have seen it became within our experience from starting it early. Two is public education.
How has the COVID-19 pandemic affected lung cancer screening and patient health in general?
As a radiology department, we saw our number of lung cancer screening cases go way down. And I think that was just simply because the referring doctors just weren't ordering them for their patients. I've seen several cases where there was some delay in diagnosis that were, unfortunately, patients will probably have a bad outcome. There was one in particular that I recall where a patient had been screened back in March of 2019 and had a normal study. And so they would have been due to be rescreened in March 2020, but then did not come in until about November of 2020. And at that time looked like they had, a stage 4 lung cancer. So, if we had been able to screen that patient in March of 2020, we probably would have, caught it a little bit sooner.
For our program, the COVID-19 pandemic has led to concern and reluctance among patients to come in for screening imaging and to come in for lung cancer screening. This is not isolated from what we see to simply lung cancer screening, but there has been a broad shift in fear and concern about coming in for healthcare in general. That leads to a concern of what the downstream effects of that may be, and concerns that we may lose some of the ground that we have gained. We hope that as things may stabilize, that people will again feel more confident in coming in for proactive healthcare and cancer screening of all types, including lung cancer screening.
Look for other episodes from TOPS that highlight practical perspectives in managing lung cancer.